All right, guys, we'll get started. There's a all in-person crowd, which is good, but we'll get going. I got this going. Those mics are off. Yeah. Welcome to EMS Challenge. We've been going, it feels like 6 months. I think it's only been actually 4 weeks, but it feels like a long time with everything going on. Thought we'll get started back early. Hopefully the communities will be open again in a few weeks and some of you guys can show up here. But we'll get started. I know there've been a lot of online meetings and education going on with COVID. I want to do something kind of non-COVID related again, get us back to the routine. So we're going to talk about some cardiac cases, some 12 leads. We'll talk about respiratory emergencies, which kind of tie into the COVID. And then at the end, I will kind of go over some of the new guidelines from American Heart with COVID, talk about some regional things going on, but try to get back to some of the routine stuff. So if you've not been here before, EMS Challenge was set up back in 2014 to provide physician-led Con Ed for the Birmingham region. We've grown this to doing the live and online. We do a cadaver lab a couple of times a year as well. We had one scheduled for this week. I know some of you guys were set up for that, but that had to be canceled due to UAB being closed. I will reschedule that for the summer. I'm looking probably June, if not June, it'll be August, and I'll post that as soon as I can get a response from UAB. That'll probably be the 1st of May before I can guarantee a time spot again. All right. So for your certificate today, email is used as a roster. So when we finish this up, you'll be given a password midway through. You want to email alabamaemschallenge@gmail.com. You will get an automatic response. You type in that password, fill out a little information, and your certificate will be emailed to you that way. So try to get those into us by today. All right, so we can get that stuff back out to you guys. So 12 leads. These things are not rocket science. These things, it's a screening tool we use in the ER. A lot of people try to make these more complicated than they should be. When I think of 12 leads, I want to make them pragmatic, something practical you can use. So I'll think about looking at the ventricular rate. Is it too fast? Is it too slow? Or is it okay-ish? All right. American Heart does a great job with the too fast by breaking it down to determining is it wide or narrow complex QRS? Is it regular or irregular? And kind of defining the way you treat those things. Great job with that. With the too slow, 3 things I think about are drugs, electrolytes, and ischemia. Anything else you can pick up on your physical exam. So obviously things such as hypovolemia, the dude that's shot in the belly, that's tachycardic and diaphoretic, and en route to the hospital, his heart rate starts breaking down 90, 80, 70, 60. His problem is not drugs, electrolytes, or ischemia. His problem is volume depleted, right? So you pick those things up on your physical exam, primary assessment. Things you don't pick up are those 3. We'll talk about some of that in a few minutes. And then okay-ish. Those are the 12 leads that are kind of either complicated and they're either scary or not scary. These are your STEMIs, your brigadas, your hyperkalemia, things like that. And the goal of this year is to talk about 12 leads every class so that you guys are really comfortable with this. There are a lot of places in the nation now that are taking off the interpretation of the 12 leads. The machine does a fair job, but people do a better job. And you can also clinically apply that. So my goal for this region over the course of the next year or 2 is to start transitioning us away from looking at the monitor interpretation of your 12 leads and you guys doing that. All right. I usually say questions, comments, or statements, but there's nobody here. So I know there's a 15, 20-second delay. If you have a question, is a chat feature? They can chat. Yeah.
It is.
So
it's under the Q&A.
All right. So you can still send out chats and ask questions that way. Please feel free to do so if you have any questions. If I say something that sounds inappropriate, it probably is. Ask the question and we'll change it. So basic things you got to know how to do on a sheet of paper with a 12 lead on it is figure out the rate. Okay. A lot of ways to do it. You can look at the monitor, but once you print that thing out, you got to be able to look at that paper and determine what the rate is. However you do it is fine, but you have one way to do it. Okay. I use the box method. So what I'm doing here is I'm looking at this and I'm counting boxes. See if I don't jack this up. So I'm counting boxes. One box is 300, 150, 100, 75. Okay. After that, it's not a big deal. If I start to continue to count and have issues and start getting bored and thinking about other things, I know they're way too bradycardic, all right? So I think regular rates, anything between 50, all right, and about 150. Everything in between there is okay-ish. Below 50 is concerning, okay? And above 150 is super concerning. And those are the rates I think about are probably cardiac in origin. So the guy with a heart rate of 140 who's hypotensive is probably tachycardic and hypotensive or something besides it being primary cardiac. Is he septic? Is he volume down? Is he febrile? Something like that. Rates more than 150, you start thinking, okay, this is probably AFib, aflutter, or an SVT, or some kind of VTAC. So rates greater than 150, super concerning. Rates less than 50 are super concerning as well, usually primary cardiac in nature. Intervals, you got to know this stuff cold, guys. You should be able to look at this stuff because obviously with the AHA algorithm, with the wide or narrow complex QRS, you got to know what a normal QRS looks like. So QRS is very important. You got to know that. The PR interval, a lot of people have learned in medic school about first degree heart blocks. First degree heart blocks are not super scary. A first degree heart block makes me think, are they hyperkalemic? Because with hyperkalemia, you get a wide PR interval, but you got to know what's normal first. The other big interval here is the QT interval, from the QRS to the T wave. Prolonged QT can cause torsades, which if it's short term, they pass out and they wake up. If it's continued torsades, they go into cardiac arrest, right? And people die from that. So be able to recognize your QRS. Is it narrow or wide? Look for a wide PR interval. And if it's really long, start thinking hyperkalemia. And then think about your QT interval when you think about syncope or dysrhythmia or somebody who's weak. All right, so let's look at basic 12 leads. So when I look at this first one, I say is the rate too fast, too slow, or okay-ish. And obviously this rate is okay-ish. The machine says 73. If I'm using my box method, I'm gonna say 300, 150, 100, about 75. So about the same, right? So my rate is okay-ish. So the next thing I want to start doing is looking at injury patterns. All right, so injury patterns for this, first place I look is I look at lead 1. I look at lead 1 and lead AVL, and then 5 and 6. These are your lateral leads, okay? So to have an ST elevation heart attack, a STEMI, you got to have ST elevation, all right, 1 millimeter or greater in any two of these leads. It could be lead 1, and it could be lead V6, or it could be V5 and 6, or it could be just 1 in AVL. You need 2, right? So I'm looking for ST elevation here, elevation concerning for a STEMI, or I'm looking for T-wave inversion, ST depression, which would be ischemia in 1 AVL and lateral. All right. The next place I'm going to look is I'm going to look inferior leads, and that's 2, 3, and AVL. This is probably the more common place where we're going to see issues here. So I'm looking for ST elevation or depression. Elevation is STEMI. I got to have 2 leads with it, or ST depression, ischemia, right? So that's inferior leads. So the red is the inferior. Is inferior. The black is the lateral. Next place we look is where? I guess nobody can answer, so nobody's here. The next place I'm going to look at my septal and anterior leads. This is V1 through V4. All right. These are your septal leads running down the middle of the heart, and these are your anterior leads as well. So elevation here is very concerning for anterior or septal MI. If you have T-wave inversion, ST depression here, it's concerning for a posterior. So V1 through V4 is kind of like the money shot on these things. The other problem with V1 through V4 is if people have an enlarged heart from hypertension, chronic cocaine abuse, pulmonary hypertension, something like that, a lot of times you see what's called LVH. So you see changes in these leads where you get big QRS waves or R waves, and it can kind of mess up the way you interpret some of this. But for the most part, elevation of 1 through V4 is a septal or anterior STEMI, all right? Next place we look at is we talked about, that one didn't show up, will be the ST depression in the V2 through 4. That's going to be our posterior. So if we have, if you have ST depression in any of these leads here, so you're going to see this come down in a T-wave inversion, that's concerning for a posterior MI, because you think about it, this is the anterior leads. So if this is depressed with T-wave inversion, then it's really up on the backside. So that's a posterior infarct. A lot of people want to get fancy and say, okay, I got changes in V1 through V4, ST depression. Let's put our leads on the back and do a posterior 12-lead EKG. That's fine if you want to do it. It's pretty academic-ish. because just the ST depression, T-wave inversion in these leads is enough to get me to call a cardiologist and get them to go to the cath lab. So doing a posterior, if you have extra time, that's fine, it's bonus points, but you don't need it. The diagnosis is made on a regular standard 12 lead showing ST depression, T-wave inversion on V1 through V4. The last place you want to look is lead AVR. So we used to talk about AVR was only good to say that if you're up in one and down in AVR, your leads are on correctly. In reality, AVR is real high proximal lateral and left main, okay? So elevation in AVR alone with ST depression, T-wave inversion, and any other injury pattern is concerning for a left main disease, a really bad STEMI, okay? So if I'm up in AVR, this is up, this is up, all right? And I got depression in my lateral leads or my inferior leads, then I'm really concerned that this is a proximal left main, left coronary STEMI, okay? Now, sometimes you'll see people get up in AVR and down laterally or inferiorly, and it's because they're older, they have bad heart disease, already a calcified there, and now they're under stress. So you got the old lady who is got known coronary artery disease, who is now septic with a blood pressure of 90 and a heart rate of 130. You may see this go up and these go down, and it looks like a STEMI or a STEMI equivalent is what American Heart calls it, all right? And she doesn't need a heart cath. She needs fluids, antibiotics, something to get her blood pressure up, and then this EKG will change. I had a guy the other day in the ER who has bad heart disease and had a hypertensive emergency. Blood pressure was running 240s over 110s, and he was having EKG changes. We popped him with a bunch of nitro, gave him some medicine to lower his blood pressure, and that EKG normalized, okay? But for the purpose of EMS, pre-hospital care, and ER care, if you see up in AVR and down anywhere else, you got to be concerned about an acute STEMI. This is just a little diagram, still it off the interweb. It kind of shows the patho behind this. So changes in AVR are coming from near the aorta where the left main comes off, all right? Then you got your inferior leads, your circumflex, and the LAD, which is your septal anterior, or if you have changes that are posteriors, either coming off the LAD that wraps around, or some people actually have a right main that wraps around. So depending on what you see, what their anatomy is, you'll see the depressions here, and then reciprocal changes either inferiorly, if they're right dominant, or laterally, if they're left dominant. Cool. The way you get better at 12 leads is that you look at a lot of them. So if you work at a place where you run 6 calls a week and that's it, you're not gonna see a lot of EKGs. You got to find a place to learn them. I recommend Wave Maven. It's online. Life in the Fast Lane is another one. Acadoodle, I think, has some I've seen on Facebook. Wherever you get them, that's fine. Get you a book if you want to. But you got to look at EKGs. You got to know normal so you can recognize abnormal. All right. So first case, and remember, we're about 20 seconds behind, but if you have a question, please put it up in the chat box, all right? This is a 58-year-old female, complaints of nausea, vomiting, shortness of breath, and weakness for the past 3 hours. Vital signs are noted 142 over 60, heart rate's 48, respiration's a little bit tachypnic, sat 95%. So what do we want to do? So if you think about the Alabama protocols, these are kind of a guideline. So patient is not having chest pain, but I got a 58-year-old female who is nauseous and short of breath. That will make me think an anginal equivalent, right? So there's something going on, potentially could be the heart. So I'm suspecting some kind of ACS. So obviously we can get a 12 lead, it's a 12 lead class here, right? So this is her 12 lead. And the question will be too fast, too slow, or okay. So we know her rate was in the upper 40s earlier. We can do the box method and kind of count this out. I'd say it's 300, 150, 100, 75, and it's 70, 60. It's too many numbers for me to remember, so I think she's a little bit slow, all right? So the next question is a little bit slow, probably in the upper 40s, lower 50s rate. So the question would be, are they symptomatic with this low heart rate? And I would say that her blood pressure earlier was 142. So I would say at this point in the game, she's fairly stable-ish, right? Blood pressure stable, she's still mentating well. All right, so I'm gonna go ahead and start looking at injury patterns for this 12 lead. So I'm looking at leads 1, AVL, and lateral. And these 2 leads here should make you go, oh my goodness, right? Or say something like that. So I got big ST depression, T-wave inversions, very concerning there, ischemia, right? Next thing I'm doing, I'm looking at leads 2, 3, and AVF. And what do we see? Yeah, my kids could pick this one up. So that is a big freaking STEMI, right? So we're up in 2, 3, and AVF. So my diagnosis is now made. I have a STEMI. I'm not going to need other 12 leads unless patient condition changes, and I want to use it for interpretation and therapy, right? So I got a STEMI right here. I'm going to finish out my pathway. I do this because I do this every EKG the same way every time. So that way, when I've been up for 2 days and it's 2 in the morning, I'm not going to miss something. So I've already looked at my rates. It was a little bit slow, so that's concerning. Now I'm looking for my STEMI equivalents, and I got laterals okay, 2, 3, and AVF. I'm still going to come through V1 to V4. Really doesn't matter at this point in the game because I'm up inferiorly. Then I'm going to look at AVR. All right. The last thing I'm going to do before I put this back down is I'm going to try to look for P waves, look at my QRS a little bit wide. All right. And I'm going to go back one more time through my injury patterns. But this one's pretty obvious. This is an inferior STEMI. So what do we do? How do we manage this kind of patient? What's the goals of therapy here? And it's hard to say that with nobody in the class, but obviously we think about, there's an old mnemonic called Mona. I'm not a big mnemonic guy. A lot of people are. Mona. The most important things for this patient right now is what? Will be an aspirin, right? So aspirin is a platelet inhibitor. Let's go back. Is a platelet inhibitor, and basically the platelet is a protein that's got connectors on it, and the job of the platelet when you have a STEMI, all right, you got an occlusion inside a vessel. So this is our vessel. Blood flow is going this way. We have an occlusion here. The body's response is to send platelets to try to fix it and other chemicals and proteins. And the problem with that is as these platelets come in here, they start sticking together and will completely occlude this and make it worse. When you give aspirin, it blocks these receptors, so the platelets cannot stick together and you continue blood flow. So these STEMIs get aspirin. The only reason they don't get aspirin is they have an anaphylaxis reaction to it in the past. If you say, what happens when you take aspirin because they have an allergy and they say they had to cut my neck, they don't get aspirin. Otherwise, they get an aspirin. People say, what if they have a history of a GI bleed? Doesn't matter at this point in the game. We're having a STEMI. This is a life-threatening event. They need that aspirin, a full aspirin, 324, 325, whichever brand you carry. What if they're on Eliquis or Coumadin, a blood thinner for other issues? Does not matter at this point in the game. Risk to benefit, they get an aspirin, okay? So chick gets an aspirin, all right? What else we can give her? If you think about the old Mona stuff, nitro is great. Blood pressure is stable in this chick. It was like 40/70. I'm gonna start IV access. I'll make sure I got fluids hanging, and then she can get a nitro. Nitro is gonna take this vessel, open it up, and hopefully restore some blood flow downstream. Now I know somebody's thinking, but she's probably having a right ventricular infarct. We got inferior ST elevations. She's bradycardic, and we're greater in ST elevation in 3 than 2. And I'd say, yep, you're right. That does meet the definition of a right ventricular infarct. However, nitro is only contraindicated if they're symptomatic bradycardia or hypotension, okay? So I would not give her an aspirin if I couldn't get IV access. But if I get IV access and she's having chest pain, nausea, vomiting, some kind of discomfort, she's going to get nitro from me, all right? But after IV access. What about oxygen? American Heart is a kind of anti-oxygen. If your SATs are greater than 95%, this chick SATs are 95, so she's not really hypoxic. I would not give her supplemental oxygen, but I give her oxygen, and I call it pre-oxygenation because the biggest cause of death in these STEMIs initially would be VTAC, VFib, or big dysrhythmia, or with these right ventricular infarcts would be complete heart block and very symptomatic bradycardia. So she would get a couple liters of nasal cannula. That way, if something happens, if she arrested in the back of the truck, I can crank it up to 6 liters, and I got passive oxygenation. Morphine is something we always talked about giving in cardiac patients as well. Morphine doesn't do a lot for the heart, except it takes you from going like I'm having chest pain, I'm nauseous, to I'm having chest pain and I'm nauseous, and I don't care. The other thing it does is it releases histamine, which causes vasodilation. lowers blood pressure, and will dilate this vessel. So there is some benefit potentially of morphine, okay? If they have soft blood pressures already, I would not do the morphine. There's no benefit for fentanyl in this chick, okay? She's not having a lot of sedative pain. It's not going to do anything cardiac. And then some people talk about doing Kona, which is ketamine. There's no benefit for ketamine in this patient as well, unless you want to make them alter and bind them a tube at the hospital. We kind of talked about that. This is just a nicer diagram of what I drew. Platelet aggregation. So aspirin inhibits these things from sticking together. When the patient gets to the ER, we give them a second antiplatelet. We'll give them heparin or Lovenox. A lot of times we give them ticagrelor, other blood thinners. And the goal of all that is to make this clot not get any bigger. It doesn't break this clot up, but the clot doesn't get bigger. That's the goal of all that, to increase and continue to increase perfusion downstream for the heart. Talked about oxygen, very important, I think, in STEMIs. It is not supplemental, it is called pre-oxygenation. The other things STEMI patients need are defib pads. 2 reasons. This chick, so that if she Brady's down, you can start pacing her, all right? Or more commonly, you see VTAC, VFib with folks having STEMIs. So every chest pain does not get defib pads, but every STEMI should, because of big risk of decompensation. And if you're running a truck where it's just one guy or one gal in the back of the truck, they go into cardiac arrest and it's just you. If you don't have the O2, you don't have the defib pads on, you're kind of hosed. You got to stop, start CPR, put all that on them. That's hard to do with one person. If you already got the O2 on them, the defib pads on, if they go into VFib, you crank the O2 up, you charge the 360, you defibrillate. If they need to be paced, you turn the pacer on. It makes it a lot easier to manage that patient. So what do we do in the hospital when you get there with this STEMI, okay? So we got 2 choices. They can go to the cath lab, all right, or we can give them lytics. So for years, we've had metrics in the hospital. Door to EKG is 10 minutes. Door to thrombolytic should be 30 minutes, okay? Door to balloon up from the cath lab should be 90 minutes or no more. These numbers are coming to the pre-hospital world. So currently, American Heart is certifying heart attack centers. These centers are tracking times back to first patient contact. So they're pulling up dispatch information when you say you're on scene, and from that point, we're timing this, and we still want to get these people licensed within 30 minutes or to a cath lab within 90 minutes. So that means early OMC 12 lead is very important. Then once you recognize that STEMI, you're popping the aspirin in them, you're getting them hooked up to the defib pads, your IV access, you're moving toward the hospital, because it's kind of the old corny statement, time is muscle, is very true. All right, so this patient shows up at my hospital. I got 2 choices. I have a cath lab available. I'm calling my cardiologist. We're getting them more anticoagulated. All right, we're drawing a few basic labs. I'm getting a quick chest x-ray to look for another trait, and they're going to the cath lab. All right, if I don't have a cath lab, I'm doing my screening process for thrombolytics, getting ready to give them a thrombolytic so that they can get lysed. We can take that clot that we had, that we have now tried to stop it from getting bigger with the aspirin and the heparin, right? I'm gonna give a thrombolytic, which is gonna bust open this clot and restore blood flow, okay? Now, it doesn't take all the clot away, but enough to get good blood flow. They still need a heart cath at some point in the next 24 to 36 hours.
Hey, Dr. Ferguson, we've got a question from online.
Sweet.
Does dehydration increase the possibility of an MI for someone with an occlusion?
Dehydrate. Probably not. So dehydration will make them more tachycardic and may drop their blood pressure, and that will make them have more oxygen demands on the heart, but it really is not going to mess up the coronary perfusion and change this vessel size, okay? Now, obviously, someone who is already had stents in, so someone who's had a heart attack in the past, and we have a metal stent in here, and they're supposed to be on blood thinners at baseline, and they're not, and now they're dehydrated, this stent has a higher risk of re-occluding and causing a STEMI. But for the typical person, dehydration should not cause you a problem. We usually get fluid boluses for these people because we're going to be giving them we want to make sure the blood pressure stays up as we give them that morphine and that nitro. The other thing we think about is there's going to be some blood loss when we go to put them in the cath lab when we stick them. So a little bit of fluid bolus is reasonable for these people. So this is a checklist that the state uses here in Alabama. There are different ones there. The goal for this is that when you have this patient, once you recognize that STEMI and as you're managing your patient with the aspirin, now you're asking appropriate past medical histories. Are you a diabetic? They say yes or no. If they're yes, you say, do you take shots or pills? If they take shots, they're going to be sicker. We got to manage that. Something that I need to know in the hospital. If they're on pills, they're probably type 2. They still have issues, but not as scary. The next thing you can say is, are you on blood thinners? Because that will determine sometimes which lytic I can give them or which intervention I can do from the cath lab. So that's important. You take Eliquis or Coumadin or Xarelto. Okay. What's another important medicine we want to ask these people before we give them nitro? Yeah, Viagra, right? So we want to ask for those things. That's also not used just for guys. That's also a medicine that we use for pulmonary hypertension. So you're seeing a lot more people who have COPD taking Viagra and things like that. So that's an important question to ask before the nitro. But what you want to do with this screening sheet is, obviously the state recommends that this is filled out on every STEMI, and I'm going to leave that there. My recommendation is that you ask these questions and this information gets relayed to the receiving hospital. So if you got a guy having a STEMI that just had a epidural done for his chronic neck pain, I can't give him a thrombolytic, because if I give him a thrombolytic, the clot that's stopping the bleeding in that epidural space of his spine, okay, is going to bust open, he's going to bleed, and he can die from that. So it's poor form to kill your patients, right? So these are important questions to ask. If anybody's ever had a intracranial brain mass, anybody that's had a shunt placed, any kind of brain surgery, those folks you cannot give a blood thinner to because there's not much space in there to bleed. But these are the questions you should kind of look over and make sure you know these. And these are things you ask as you're taking care of the patient. I'm not going to stop, not give aspirin to ask these questions, but I'm going to give my aspirin, I'm starting my line, hanging my fluids, I get on the monitor. And then as I'm doing that, hey, any recent surgeries? You ever had a stroke, hemorrhagic stroke, any brain surgery, any recent spinal surgery? Do you take blood thinners? Are you a diabetic? If so, do you take shots or pills? And you got that history done in a matter of a few minutes, okay? And this is important to me because the patient shows up to me in the ER and I walk in, and as you transfer them over, they go into VTAC or VFib. If I can't get them back in that first shock, and I see that 12 lead that you did that shows a STEMI, they're going to be lysed. But if you tell me, oh no, wait a minute, he had a hemorrhagic stroke 3 weeks ago, I know now I can't lyse this guy, and I got to start talking to my cardiologist about what can we do. Can he go to the cath lab? Can I put him on ECMO? Okay, those are things you got to think about. Am I talking too fast, Chief Ward?
I've got a very elementary question.
Yes, a question.
When you're doing the mono or the,
Yeah.
it seems like to me it should be, but.
Yeah, I can't. That's a.
Yeah, and you're trying to decide whether to give them a nitro or not. What if the patient says, well, I took Viagra yesterday?
Yeah. So 24 hours, you're probably fine. Okay. So 20. Yeah. So I would say less than 24 hours, you got to be careful. Now, this patient who heart rate is 50, blood pressure 140. If they tell me Viagra 24 hours ago, I'd probably give them some fluids first because they're a little bit bradycardic already, right? So it's a kind of an iffy to give the nitro at that point. Now, if I had somebody had a heart rate of 80, blood pressure of 170 over 80, and they took Viagra, 14 hours ago, I'm probably going to start the IV, hang fluids, and give them a nitro. So that's reasonable. Now, if you pick them up at the hotel and they're having chest pain and they're still in their robe on the bed, I probably would not give them the nitro, okay? All right. Waving at me, yeah. All right, so this is that patient's cath. So patient went to the cath lab. All right, you can see that hopefully it shows up pretty good online, but they had a big RCA occlusion. So this is the angiogram. This is down the right heart, pretty well occluded right here. They put a stent in that. Add some more IV antiplatelet, anticoagulation medicines, and you can see now we got great blood supply distally, right? So cath lab is the preferred method of choice in America for this. There's some pretty good data out from the Europeans that giving people lytics does just as well. There's some good data that giving somebody a pre-hospital thrombolytic such as Retavase makes a big difference as well. If you screen the right people, if you give it to the right patients, that they have no risk for major bleeding. So patient got to the cath lab within 90 minutes, okay? We still don't know what kind of damage downstream is going to become because of this, because of that poor perfusion, right? When did that STEMI actually start? We know when we came in contact with the patient. That's why I think that my goal will be to move toward pre-hospital Renovase, giving these folks having STEMIs a thrombolytic. So if I can give them that thrombolytic, okay, at patient contact minute 12 and knock off over an hour, maybe there's not much muscle death downstream, and this person doesn't develop congestive heart failure and problems from that. Now, I give that lytic in the field, we get some blood flow back. They still need to go into the cath lab 12, 24 hours later, look for underlying problems, maybe still get a stent. But what I've done is I've increased blood supply distally so that the heart doesn't die off. So, food for thought.
Dr. Ferguson, what's the biggest risk factor for giving lytics either in hospital or pre-hospital? What's the biggest?
So you got two problems.
Obviously.
Hemorrhage is the big one. So you got to screen these people. You got to make sure you don't give somebody a thrombolytic that's going to bleed to the brain. That's the big thing. If somebody has GI bleeds from this, we can usually fix that with blood products, okay, and platelets and FFP, things like that. But the biggest risk is bleeding in the brain, okay, or central nervous system. The other risk is once you give somebody a thrombolytic, you're going to see all kind of weird rhythms. So think about if you were to sit on your couch for way too long and your leg goes to sleep, right? Lack of blood supply. When you get up and start trying to walk, your leg kind of cramps and spasms and twitches, right? Heart's going to do the same thing. So as this heart reperfuses, you have a big risk to seeing runs of VTAC, VFib, other dysrhythmias, okay? So that's the other risk to this. But that's something that we do in EMS all the time already is manage dysrhythmias. So my opinion, I'm a big advocate for Renovase, for pre-hospital. The problem we got to do, the thing we have to do to get there is we have to be competent in 12-lead interpretation and be competent in screening these people out. All right, so same patient now, okay? Same chick, same EKG, 54-year-old female, same symptoms, shortness of breath, diaphoresis, a little bit of chest pain, but now her blood pressure is 80 and she's altered, and we have this heart rate. So we already saw this 12 lead. So 12 lead comes out, patient's altered. My partner's getting a quick history from her best they can. She's altered. I'm doing an AccuCheck or a blood sugar. It reads, 240, so I'm happy. If it reads low, I fix it. If it reads high, I know they're probably in DKA or some other issue. Everything else doesn't really matter. So my partner's giving her aspirin and starting IV fluids. We look at this 12 lead, same one we saw a little while ago. Too fast, too slow, or okay-ish. It was still too slow like last time, except now I have a chick who was altered with a low blood pressure. So now she is symptomatic bradycardia, okay? In addition to the fact she's got this big freaking STEMI, all right? So now things change. So now the problem, the fact that she's hypotensive and altered, we know that her heart's not pumping well, brain's not getting perfused, so she can't tolerate this heart rate, okay? So we got to do something with this. So she's getting her aspirin, she's getting IV fluids, and now we got to think sort of like AHA and go down that algorithm of bradycardia. I'd already mentioned the 3 causes for it. You think about drugs, electrolytes, or ischemia. For her, I think we know it's ischemia based upon that 12-lead EKG, right? So she's going to get fluids, aspirin. Is she going to get nitro? Heck no. She's going to get morphine? No way. What drug does she need now? Atropine, yeah. So a lot of people are trying to get away from atropine. Atropine is a relatively low-risk drug. It's going to increase her heart rate. People say, what if she has a heart block or a complete heart block? It's not going to help. I'm like, you're correct. It's not going to help, but it's not going to hurt her, okay? So I would give 1 milligram of atropine. It is old school, low risk, easy to do, 1 atropine. If I get her heart rate up to 70, okay, and she's still altered, infused, and hypotensive, then I'm not going to do any more because her rate is now up. That wasn't the problem. The problem is not rate related. It's probably her pump. The heart's not working well because of the big freaking heart attack. So atropine. So I give atropine, rate doesn't do anything. Blood pressure is still 80. Okay, she's still altered. What's the next drug I can do? I know I preach about this a lot on our classes here. I like dopamine. Dopamine is great for cardiogenic bradycardia, cardiogenic shock. She is slow and hypotensive. Dopamine's wonderful, okay? So the way I do this is I prime the bag, I start the fluids, I crank it open. As I'm cranking the fluids open, I'm thinking about, does she need a second IV access? Are the pads on? What's going on? I give this a few minutes. If her heart rate goes up, I slow the drip down to 10 mics per kilo per minute. If it doesn't get better, I'm still going to slow it down to 10 mics per kilo per minute and think about my next plan, okay? So Alabama protocols talk about we give 0.5 of atropine for the first time. That's going to be changing. In June, we can just do 1 milligram. Makes a lot more sense. We're also talking about hopefully in June going to pacing as being category A, last I heard. But so after dopamine doesn't work, the next thing I'm thinking about is calcium. I use calcium because a lot of times you see people who are hyperkalemic get slow and wide rhythms. Calcium treats that, low risk profile, potential benefit. In the setting of a STEMI, I may not give calcium right off the bat because I don't think it's hyperkalemia. I see a STEMI going on. But again, calcium increases calcium stores in the cell, and that's how dopamine works, atropine, all these medicines work anyway. So risk to benefit, it's not going to hurt. So a little bit of calcium is not bad for you. Obviously, what this chick needs, though, is she needs pacing, right? So she needs to be paced to that point in the game. The problem and benefit with that is a lot of times when you pace people having a STEMI because their heart's just not working well, when you get that heart rate up to 60 or 70, they become awake and alert. So you know you got somebody that you're pacing at 70 beats a minute, who has a blood pressure of 140, and they're using profanity at 70 beats per minute too. So at that point, you got to think about what do you do? Maybe a little fentanyl, maybe a little Versed, okay? But if you're going to do that, that needs to be med control, and that needs to be, you need to be ready to manage the airway as well, okay? In the hospital, if I got to pace somebody, as soon as I pace them, I get capture and I got good blood pressure, I'm going to electively intubate them. So that way in the cath lab, if something happens, they get altered to sedate, airway is already taken care of. But remember, when you intubate somebody, what happens to the blood pressure? Blood pressure goes down. So make sure you're ready for that because you don't want them to be hypotensive with this because they already have heart problems. So they get a good fluid bolus, maybe increase your dopamine while you're getting ready to intubate them as well.
Hey, Dr. Ferguson, could you talk a little bit about what the mechanism is there? Is that a Valsalva type reaction?
With blood pressure?
Yeah.
Oh, no, sorry. So when you take somebody breathing normally, it's passive ventilation, right? So when you put them on positive pressure ventilation, it's going to decrease the blood return to the heart because there's more pressure in the chest cavity. So it's like dropping your preload is what it is. So that's why you want to give a fluid bolus, give a little something to increase the venous return to the heart. That's sort of like why we don't do CPAP or BiPAP with somebody who's hypotensive because it drops their blood pressure. And you see it all the time in septic patients that you go to intubate. They're altered, pneumonia, hypoxic. You're going to tube them, but the heart rate's 140, blood pressure is 70. If you tube them without correcting their blood pressure, then they go into cardiac arrest, peri-intubation arrest. So those folks, we give a bunch of fluids to. Sometimes we do push dose epi or push dose phenylephrine, and sometimes we just hang dopamine or levofed and start that to increase the blood pressure. So when we intubate them, they won't drop.
Gotcha. Yeah, I think everybody's kind of had that idea thrown at them a lot about the rising thoracic pressure causing hypotension.
Yeah.
The part about that that's confusing is in a lot of the textbooks or literature, you see stuff about limiting suctioning time to prevent hypotension, and I've never quite understood the rationale behind that.
So I don't think that's a real thing. So I got a case that's going to talk about some CHF, and I'll talk more detail about that, but I don't think that's a real thing. I really don't. The other thing to think about on bradycardic patients is people talk about what about blocks. So if I have a patient with a heart rate of 40 who is symptomatic, I really don't care what type of block it is. My pathway is going to be the same. Okay, fluids, atropine, dopamine, calcium, pacing. All right, blocks are something we do in an academic setting once the patient is stable. Okay, if someone has a high degree AV block, second or third degree block, it's probably going to take them to be paced to get fixed anyway. All right, so once they get paced, it doesn't matter what kind of block they have because if it's being paced transcutaneously, they're going to go to the cath lab and get a transvenous pacer. All right, so we got to know our blocks and think about them, but in reality, sometimes it's tough to tell. Sometimes you see alternating third degree blocks, second degree blocks, or no block. So don't let the blocks confuse you. Treat symptomatic bradycardia the same way every time. Inappropriate humor. I need to get a new slide. It's been in there too long. All right, so this is one I show a lot in the class. This was an older lady from a nursing home who had a UTI, nursing home call because the patient was vomiting. She also complained of some jaw pain, but she had a lot of dementia, really hard to tell what was going on with her. The medic for this patient was pretty astute, did a good job, recognized Old person with angina equivalents, nausea, vomiting, got a 12 lead. We look at this rate. I said the rate's okay-ish. It's in the 70s, all right? The next thing I'm gonna do is I'm gonna look for injury patterns. I'm looking at leads 1, AVL, and lateral. And then I'm gonna look at 2, 3, AVF. I got some T-wave inversions. It's not a STEMI, but it's concerning. I go to V1 through V4, and what do we see here? If this was pointing the other direction, it'll be a STEMI, and we'll call it an anterior STEMI, but it's not. It's through here, so it's a posterior MI. Machine does not pick it up. Remember, the machine is not 100%. The machine cannot apply things clinically either, all right? So now I have a old lady that's demented, can't give me a great history, who maybe has some jaw pain and is vomiting. So now she has a STEMI. So this medic changed the destination hospital. She put her in our STEMI system. She got an aspirin. I think she threw it up, but she still got it. He also put her on pads and some O2, all right? And that was good because a few minutes later, she went into this, right? Biggest cause of death in STEMIs early on is a dysrhythmia, VTAC, VFib, or symptomatic bradycardia. So medic was cool. He put a cigarette out. I'm joking. He wasn't smoking. Charged, defibrillated, and when she got to the hospital I was at, this demented little lady was mad, cussing and screaming at him. But the point of that was an astute medic recognized a atypical presentation of angina, got a 12 lead that picked up a STEMI, and he saved a life. And that's what it's all about, right? So pretty cool stuff. He was a fairly new medic too, did a great job. Here's another one I show quite frequently. Too fast, too slow, or okay. I say the rate's okay-ish, it's in the 70s. All right, I look injury patterns. I look at leads 1 in AVL. That actually makes me a little bit uncomfortable. That's 1 millimeter. That's gonna make me open up my eyes a little bit more, drink a little bit more coffee. And I look at V5 and V6, and what do you see there? Yeah, that my kids could pick that up, right? So I'm still gonna go through my routine. So I'm gonna look at 2, 3 in AVF, V1 through V4, and this is just horrific, right? This is what we talked about years ago about Pac-Man ghosts, or our tombstones. So this is a big, big STEMI, right? So we got the whole anterior portion of the heart, the septum, the middle of the heart, and the lateral. So this is like a left main. I'm surprised that AVR is not up with that, okay? But what does the machine say? Sinus rhythm, pacemaker, no analysis. That's ridiculous, right? So again, you guys got to be able to read 12 leads. All right, because the machine messed this up. And if you miss this and the guy sits on a wall at a hospital for 30 minutes, they will go into cardiac arrest and that dude just dies, right? Very important. All right, let's see what this one is. This is a 44-year-old male, history of heart disease, complaints of chest pain. Heart rate's a little bit tacky, all right? Blood pressure 182/96, respiration is 24. Sat 96%, AccuCheck is 200. Remember, low is important, high is important. Everything else is kind of fluff, all right? And that's his 12 lead. Too fast, too slow, or okay. That's a bit fast, right? Yeah. So this is a bit fast. I'll say it's the rate is 300 and 150. Yeah, so it's up there. So it's probably like 170, 190. That's just 221. Doesn't matter. It's greater than 150, right? So the next question will be, is it narrow or wide? I would say this QRS looks fairly narrow. All right. And is it regular or irregular? People, you don't put it up on the monitor. You put your hand on the patient's pulse. You feel on the radial pulse, the carotid, to see if it's regular or irregular. It rates that fast. It's hard to tell sometimes. So this looks like SVT to me. Okay. All right, so how do we manage SVT? Yeah, adenosine is great. Yeah. So IV access, and they get, how much adenosine can we give? Yeah, 6 and then 12. So 6 works for the most people. It's about a 94% conversion rate. I like just giving 12. That's 99, but 6 does pretty fine. So they get IV access. I'm gonna put some supplemental, or excuse me, pre-oxygenation on them. All right. Then on the 3 lead, you can put the defib pads if you want to. You really don't have to. Adenosine is a fairly safe drug, and then 6 of adenosine. All right. In reality, this patient was having chest pain. So someone took the algorithm chest pain and said, all right, they got chest pain. I'm going to give them some nitro. So why would this patient with a heart rate of 220 by that have chest pain? The rate is too fast, right? Yeah. So even if I saw a STEMI here, which I don't, I do see some lateral stuff. This is a strain pattern. That's because their heart rate is so freaking fast. The heart's not perfusing, right? So we got some signs of injury, right? But I think it's all rate related. All right. So adenosine will be good. Nitro was probably not a good idea. In reality, nitro made this guy vagal. And how do you treat SVT besides adenosine? Vagal maneuvers, right? So he got some nitro, vagal, and came out of SVT and did okay. But the point of that is you don't want to give nitro for chest pain if the rate is 160, right? So interesting stuff. I couldn't get the other EKG to load up after that.
Does the heart not speed up more if you give nitro and dilated the vessels?
Yeah, but really the heart's at max rate right there already. You're not gonna get much faster than that. That's fast as you can go physiologically. So I think what happened was he got the nitro and he vagal and he broke out of it. So I can't remember what this case was. Let's see if we can go down. Yeah. So this was a guy that there was a ALS unit that didn't transport on scene. Had the patient who was 46. He had chest pain. They said they gave him aspirin. His vital signs were stable. They put an IV in him. 12 lead was okay. He wants to go to hospital X, and all you got to do is pick him up and take him in there. So what do we need to do on patients like this? I know for the guys that do first response and transport, it's kind of a no-brainer. But there's some folks out there to watch that do just transport and aren't on scene initially. So the point of this is you do the same thing as if you were the first responder, okay? So we need to trust everybody, all right? But we need to, what's the phrase? Trust but verify, right? Very good, yeah. So if I got this patient, they hand him over to me, he's on my stretcher, they say he's had chest pain, EKG was fine, he got his aspirin, he wants to go to hospital X. I'm gonna say, great, thanks. I'm gonna turn to the patient, I'm gonna get a quick history, okay? I'm not gonna spend 30 minutes on scene doing that, all right? But I'm gonna say, hey, how long have you been hurting? Any health problems? Do you take blood thinners? Are you diabetic? The same things you do all the time, all right? I'm gonna say, did you get your aspirin? Very important, okay? Are you allergic to anything? Then what I'm gonna do, I'm gonna take it, I'm gonna say, hey, can I see your 12 lead? So this is the 12 lead they got. Excuse the quality, my scanner's not working well. It's tough to get that covered right now. So too fast, too slow, or okay. I'll say the rate is okay-ish. Rate looks probably about 90-ish. I'm gonna look at injury patterns. I'm gonna look at leads 1, AVL, and lateral. And this makes me very uncomfortable, as does this. And actually, as does this. That morphology makes me uncomfortable. So I'm looking at lateral leads, very concerning. 2, 3, and AVF looks reasonable. V1 through V4 looks reasonable. AVRs, nah, not too scary. I got P waves, my QRS looks fine. My QT is a little bit long, all right, but not super scary. But what is this? This is a STEMI, right? So now I just got a patient from a provider, a colleague, who said the EKG was all right because the machine said EKG was okay. So point to that again, trust but verify. If you're responsible for that patient's care, make sure you look at all the data, all right? Happens all the time in the hospital too. Doesn't mean somebody missed something, okay? It just means we got to do the right thing. So at the hospital, when you come in, you give me a report about the patient, I'm gonna listen to your report, but then I'm gonna look at your 12 lead, and I'm gonna turn to the patient and ask probably the same questions you just asked. Then what am I gonna do? I'm gonna call my nurse and they can come over and do a 12 lead on that patient, right? We don't want to miss things that get people hurt and kill people, all right?
One of the things that I see is this is a different manufacturer EKG from the other ones that you show, and they all can have times that they don't show the STEMI.
Yes, exactly. So in speaking with some of the manufacturers, there are 2 algorithms these machines use to figure out STEMI or not STEMI, and neither one is 100% accurate, okay? The best thing is have a person that has looked at a bunch of EKGs and recognized normal, abnormal, can also apply it to a patient. So I had a gentleman several months ago that came in. He had gout. He had a swelling in his great toe, and that was his complaint. They got a 12 lead on this guy. because he was bradycardic, and he was almost 80, had a heart rate of 40, and he was in complete heart block. He had great blood pressure, mentating well. He came in for toe pain. So this is a guy that was probably in better shape than me, who had heart disease and a heart block, and didn't need anything done because he had no symptoms from that. They had an abnormal EKG. So the point of that is we got to apply these 12 leads clinically. What's going on, right? Sweet. This is this guy's cath. So obviously he's got a lateral MI or circumflex. So LAD, see where it's occluded there. He gets a stent, and now look at that. That whole left side of the heart open back up. Very important. So look at your 12 leads, talk to your patients, even if you're not the first ones on scene. If you're the medic in charge, look at them, look at the 12 lead, repeat the 12 lead. If your first 12 lead is not a STEMI and you're concerned, repeat one every few minutes. It's not going to hurt the patient. They don't get charged per EKG. There's no radiation, there's no risk, right? If your first 12 lead is a STEMI, you don't need any more. You got all the data you need. Show up at the hospital, give that 12 lead to a doc. He's going to call cardiology. All right. Original concepts. I know I've said this to you guys a million times. Paramedics were great at reading junctional tachycardia, AFib, VTAC, bradycardia, managing that stuff. That's what we learned. We're the gurus of 3 leads. 12 leads now, because Redivase, these pre-hospital lytics need to come to our communities, and we can't get it there till you guys get them down well. As you look at a lot of them, you look at a whole lot of them, okay, and then you get QI'd, and by QI, I don't mean you get beat down, I mean you get feedback. You say, okay, patient went to the hospital, I thought the EKG was a STEMI, what did it really show? And then you find out, well, the ER doc said, yeah, it looked like a STEMI to him. And cardiology said, nah, it wasn't a STEMI, but he went to the cath lab anyway, and he had disease. So if you don't get feedback, you can't learn from that. And that's one of the things we're trying to push out through the STEMI system here, and plus having more docs on staff that are involved with EMS. What time is it, Chief?
It is 5 till 10, sir.
Perfect. This is Chief Ward's favorite slide. He's a big David Bowie fan.
Oh, you're killing me.
So remember, changes are coming to pre-hospital care. We got door to EKG, 10 minutes in the hospital. We're going to start saying first patient contact to EKG, less than 10 minutes. So that's for you guys, all right? We're going to say first patient contact to cath lab, 90 minutes. First patient contact to thrombolytics, 30 minutes. Got to do it. That means we got to work a little bit. All right, let's take about 5 minutes and we'll come back and we'll talk about some respiratory emergencies. And we'll talk a little bit about COVID, since that's the popular thing to talk about these days.
I know what CD to get you now then.
Thanks, everybody. We're going to take a few minutes break. We'll be right back. Please stay tuned. We've got some more great information coming up. Hey, there seems to be a problem with the attendance form for some people. I put a direct link to the attendance form in the chat feature, so you might have better luck clicking on that. Otherwise, make sure to send the email to alabamaemschallenge@gmail.com. The password for today's class is STEMI, S-T-E-M-I, STEMI.
All right, guys, we'll get started.
All right, everybody, welcome back. We're going to turn it back over to Dr. Ferguson for the back half of the lecture.
So there was a chat comment about what does VSS stand for on that last slide. That meant vital signs were stable. There was another question about another mnemonic, and I think I just was tired and put a typo, so I won't mention that one. Yeah, yeah, it does rhyme with donkey, so yeah. All right, let's talk about some respiratory emergencies. Next week, we're scheduled to talk about lower airway disease. I'm going to talk about that today, and we'll change up next week a little bit. So respiratory distress, I've had numerous people kind of tell me, protocol do we use? So don't be offended when I say this. I think that y'all have to make a diagnosis of what's going on with the patient and then determine what to do. So protocols are kind of like a guide. These are your scope of practice. So you can use a BVM, an oral airway, you give neb treatments, you can use CPAP, you can intubate, okay? But I'm not a big fan of putting this in an ABC. So, you know, you got to look at the patient, determine what's going on with them, and then provide the right care. All right, so let's talk about some lower airway stuff. Lower airway is what we're going to talk about today. So obviously, quick anatomy review, basic structures. When you think about lower airway disease, you're talking about anything below the trachea. So we're not going to talk about croup or epiglottitis, things like that. We're going to talk about basically COPD, asthma, pneumonia, and then some CHF stuff. So you have the trachea and bronchi. You have two. You got 3 lobes on the right, 2 on the left. Heart kind of hangs out in the middle. You get down deeper into lung tissue, you have lung tissue itself that has a lot of functions besides just oxygenation and ventilation. But then you have the air sacs or the alveoli, okay, where all the gas exchange takes place. All right, so that's basic anatomy for the lungs. More of a clinically relevant picture there. Remember, the diaphragm is a very flat muscle that runs under all this. With inspiration and expiration, it gets up to the nipple line almost, all right, and then go way down low. So you can have injuries, abdominal injuries way up in the chest with inspiration and expiration as well. The clavicle run high, so your lungs kind of go above the clavicles as well, and that comes into play if you're doing IV access. So if I'm doing a big central line in somebody's neck, there's a risk of poking this lung and causing a pneumothorax. Not a big risk doing an EJ line, but it's still there, all right? But neck trauma is very because of that. You also think about vascular structures damaged in that area, okay? The lungs are wrapped in pleura. There's the visceral and the parietal, but in short, you think about it, I think about it as organic saran wrap that's attached to the lungs. And then another layer of that stuff that's attached to the chest wall and allows the ribs, the lungs to inflate, deflate with inspiration, expiration without a problem, okay? And this is stuff I can show y'all in our cadaver lab when that comes back up around in June or so, okay? So ventilation, oxygenation, and perfusion. We talked a lot in EMS Challenge about oxygenation, okay? So we talk about passive oxygenation, right? So you can oxygenate somebody who is not breathing. So we do that before we intubate folks, right? So we put a nasal cannula on them, we crank it up to 6 liters, we're bagging them over that, and then we take the bag off, and we're gonna give them passive oxygenation as we intubate them. So there have been studies, and actually in reality, we even do a brain death test in ICUs where we have somebody that's on a ventilator, they're intubated, and we're looking to see do they have brainstem function. So what we do is we take them off the ventilator, we drop a nasal tubing down the ET tube and crank it up. And you sit there and you watch this patient on off the ventilator, but intubated, and you watch their SATs, and their SATs say 100%, and they're not breathing, okay? And what we do is we watch for a little while, and we're trying to see what their CO2 goes to because they're not ventilating. If their CO2 gets to 60, 80, 90, 100, and they don't breathe, we know they don't have a brainstem reflex and they're probably brain dead. But we learn from that is that you can oxygenate somebody pretty good who's not breathing. So that's why we talk about putting a nasal cannula on somebody when you go to intubate, cranking it up 6 to 8 liters. We know they're going to stay oxygenated very well with that, without ventilation. That's why a big push we've had lately with our ketamine use. When you give someone ketamine, it doesn't make them get hypoxic. It makes them quit breathing, right? The ventilation slowed down. So if they desat, you know they're not breathing well. But if you put them on oxygen, their sats will stay up and they still won't breathe very well. And they'll retain CO2 and go into cardiac arrest. So remember, there's two things. There's oxygenation and ventilation. Oxygenation is fairly easy to do. Ventilation, you got to move the chest. You got to expel the CO2. And that takes ventilation. So that's when it comes into place where the guys who have sleep apnea, the really big folks have sleep apnea or obesity-induced sleep apnea, you know, they may need a nasal trumpet, assisted ventilation to blow off that CO2. Perfusion is basically the exchanges of gas in the lungs. So for perfusion, you got to have oxygenation, ventilation, and cardiac output. So that's all three. So important terms to remember. We kind of talked about that. So at the cellular level in the alveoli, basically you got blood supply that comes from the heart that has no oxygen. It goes around, these vessels wrap around these alveoli. The CO2 diffuses out, O2 comes in, and the blood keeps on trucking, all right? But if the lungs don't compress, don't expel the CO2, that CO2 stays there, and then it goes back into the bloodstream, and you get CO2 narcosis. So let's talk about some lower airway disease. We're going to talk about COPD, asthma, pneumonia, and CHF. So 40-year-old fella with end-stage renal disease dialyzed about 4 days ago. He's got shortness of breath. All right. He's got crackles in his lungs. He's alert. He's got lower extremity edema. So there's a mnemonic out there. There's two mnemonics I like. I like ABC. That's easy to remember. And then the LMNOP is another mnemonic that I like, okay? And I work this backwards. So this is a chest x-ray. This should be nice and clear. So I got this guy on dialysis who was full of fluid, all right? And he's in flash pulmonary edema, and you can see that all through there. So I'm gonna start treatment for this guy, and I use P first, and P stands for position or pressure, all right? So I see the residents make this mistake all the time. Guy comes in by EMS on CPAP or BiPAP, short of breath. We scoot him to the stretcher in the ER, and the residents want to lay him down to do the evaluation, and you can't breathe laying down, right, if you're full of fluid. So these guys, so you want to sit this guy straight up, all right, and that's going to make this fluid track down so that the top portion of those lungs we talked about can still get gas exchange. If you lay him flat, this is going to layer out, and you won't be able to do that. You're going to kill them, okay? Same thing if you intubate these folks who are end-stage renal disease or flash pulmonary edema. You really want to intubate them with their head up as much as you can. Or if you have to lay them flat, you tube them, and then you raise them up again because you cannot bag through all that fluid, all right? The other thing about the position and pressure is the pressure. And we kind of talked about this earlier when we talked about low blood pressure using intubation or CPAP or BiPAP. Most people who have pulmonary edema are not total body volume overloaded. They just have too much volume in the wrong place, the lungs. Most of the time it's due to the heart not functioning well. Now with dialysis, it's different. Those guys can't excrete fluids. So if they've gone 4 days of taking in fluids and can't pee it off, they'll be total body overloaded. But still the problem is there's too much fluid in the lungs. And if we shift it from the lungs to the legs, they can breathe and live until we get them to dialysis. So what positive pressure ventilation does, BiPAP, CPAP, or intubating, okay? There's negative pressure in this system right now as I'm walking and talking and breathing, okay? That's how I breathe in. Negative pressure makes the lungs contract so they can breathe the air in. When I switch to positive pressure ventilation, that makes the resting pressure inside this whole chest cavity increase. Because that's increased, it makes the amount of blood that comes back to the heart less. So now I have less blood return to the heart. which lowers blood pressure. So if this dude has a blood pressure of 220 over 140, too high, right? The heart can't beat against this. So it's hard for the heart to beat against this and get the fluid out of the lungs. If I put them on positive pressure ventilation, because of this, I'm going to decrease the blood return to the heart, and I'm probably going to drop this blood pressure by 20%. So now I'm down to about 190 over 110, okay? So now the heart can work better and pump the blood out of the lungs. So less blood comes into the heart, but more blood comes out of the lungs into the left side of the heart and goes out. So I'm reducing the volume with each heartbeat. And we talked about that LMNOP, N-O-P. So position and pressure, we've done those two things. Oxygen helps with oxygenation, duh, we know that. Nitro does two things. It lowers the blood pressure even more. So now they're 160 over 80. And what does nitro do to preload? Drops preload too. Yeah, it dilates this vessel, so even less blood goes to the heart. Remember, arteries have muscles in them, so they can squeeze the blood as it pushes along. Veins do not. So we dilate this vessel, and it's like a floppy hose. Fluid does not return back to the heart. So that makes it each heartbeat increases the amount of fluid that gets out of the lungs. Okay? Morphine is the M, and morphine obviously causes a histamine release, which makes this vessel get bigger, which decreases preload. So that's all we're trying to do, was we increase intrathoracic pressure, which will lower blood pressure, decrease blood return to the heart, and then we want to vasodilate or decrease preload with nitro and morphine. Obviously, Lasix is useful if they have a functioning kidney and a guy with dialysis. 40 Lasix is not going to do anything for this guy, or even 200 of Lasix. So that'd be my last choice, and for dialysis, I won't even use that. So these guys, I'm going to sit them upright. I'm going to put them on CPAP. If you have a ventilator on your ambulance, and you can do that, BiPAP is great. Oxygen, nitro, and morphine. Dialysis patients are notoriously hard to get IV access. If he's got a 220 over 140, what I'm going to do is I'm going to sit him up. I'm going to pop a nitro under his tongue without IV access. I'm going to put him on BiPAP, and he's going to be fine, okay? Unlike my chest pain patient who has a pressure of 140 and a STEMI, I'm not going to give them a nitro without IV access because I don't want to drop their blood pressure. This guy, my goal is to drop his blood pressure. And to be honest with you, in the ER, sometimes I give them 2 or 3 nitros under the tongue and put the BiPAP. I don't recommend you guys doing that. You get in trouble for that. You're probably okay, but don't do it. Do one at a time, okay?
Hey, Doc.
Yes, sir.
I think one of the key points here, and I'd like to hear your thoughts on it, is when you have somebody in severe acute CHF particularly, is to kind of get the pressure to start going down and the fluid to start shifting before we start moving them.
Yes, yeah, there's no reason to put them in the back of a truck because it's hard to manage them. Trying to move them is going to be a pain. You're not going to be able to ventilate them while you do that. So I should have mentioned this earlier. Okay, you guys practice medicine in the pre-hospital world, okay? You stay, you manage this patient, you get them stable, then you move them. A STEMI is different. A STEMI has a definitive care. It's like a trauma. You can't fix somebody that's been shot in the chest. You can't fix a STEMI at this point. We don't have Renovase, right? Those guys, you load, you go, you work as you're moving. This guy, you sit there on scene till he gets stable. It may take you 20 minutes, okay? But 20 minutes of CPAP or BiPAP and preload reduction, now he can take that mask off and they can stand up, get on your stretcher and go to the hospital. All right? I agree. Yeah, we stay on scene and manage these people.
I've noticed over the years that a lot of those patients seem to crash when we put their feet up on the stretcher. And I don't know, it's all anecdotal. That's a very narrow window, but you wonder if even that much pressure change by elevating their feet changes the hemodynamics of their heart enough to put them in a dysrhythmia.
Yeah, who knows? I can tell you, so in the hospital, if I had a guy sitting in a ER stretcher with this blood pressure, hypoxic, that I'm thinking about doing BiPAP, there's no way I'm going to move him from a hospital stretcher in one room and move him to a different room or move him to the x-ray table or do anything like that until he's stable, because people die with that. So stay and play with these folks. Talking about raising the legs up. There are some lectures out there that are like, they call them myths of EMS or myths of emergency medicine. They talk about the leg raise really doesn't increase blood pressure in people who pass out, things like that. However, if you also look at some of the tests we use in the hospital, we use a NICOM test or a CHEETAH that looks for fluid responsive patients and sepsis. And one of the ways we look for that is we have them hooked up to a machine, IV fluids going, and we raise their legs and check some different pressures with them. So the point of that is, we're probably right. Moving these people and then raising the legs up is probably going to return fluid back to the heart, which we don't need, okay? There's no hard data for that, but common sense makes you think that's probably the case. And common sense also is manage these folks on the scene. Don't try to move them when they're freaking dying in front of you. Y'all can manage that. Now, if you're a BLS agency and you don't have CPAP, BiPAP, you can't give nitro, you don't have a choice. You got to do something, right? You got to start moving. But if you're ALS, you can manage this patient. Contraindications of CPAP, BiPAP, obviously a pneumothorax. And why is that? If you think about, I'm not an artist, that's the heart, those are your lungs. If I got a pneumothorax here and I do positive pressure ventilation, what's going to happen in this pneumothorax? It's going to get bigger and bigger and go to a tension pneumothorax, and people die from tension pneumothorax. All right. If they're not breathing, you really can't use BiPAP or CPAP. They need what? They need to be bagged. They need an oral airway, BVM, or need to be intubated. Okay. If they're unconscious, the problem with that is they're probably not breathing. The other problem with that is they're at high risk for aspiration with that. So if they're unconscious, unresponsive, they probably need either an OPA or a nasal trumpet and a BVM. Shock means they're hypotensive. We already know that they're already hypotensive. We'll make them more hypotensive with this, so we can't do it. Nausea, vomiting, it's poor form to put somebody on a mask, strap it to the head as their vomit, because it's not going to do any good. They're going to aspirate that. Obviously, if they have facial fractures, abnormalities. We talk about active upper GI bleed or recent gastric surgery. So if somebody has known esophageal varices and they're vomiting blood, I mean, duh, we're not going to do that. Recent abdominal surgery, you don't want to put them on BiPAP or CPAP, because the problem with that is you're going to, no matter how good you are with the BVM or CPAP, you can get some air in the belly, and it's going to cause that to distend, and you can perf some of those recent sutures. This person that has this and needs CPAP, BiPAP, needs to be electively intubated so we can put a tube down their trachea and ventilate them. Okay. We've already talked about the LMNOPs. Any questions out there in internet land? If so, put it in the chat box. I know you're a few seconds behind us, but I can come back to the slide. This is a simple principle that a lot of folks get confused on, understanding how CPAP, BiPAP works. For years, we thought the increased pressure just forced the fluid out of the lungs, and it does do that. But more importantly, it increases the pressure inside the chest cavity, which decreases blood return. And that drives all your pathophysiology, all your benefit from this. We talked about that.
Hey, Dr. Ferguson.
Yes, sir.
What about the issue of atelectasis during CHF and other pathologies where we have the collapse of the alveoli? The CPAP physically holding the alveoli open?
Yes.
What's the mechanism there? Is that just?
It's just more pressure. So it's in expiratory pressure. So normally when you breathe, when you exhale, a certain amount of air stays in the lungs. If you have them on CPAP or BiPAP, you can increase the amount of air that stays in the lungs, and it keeps those air sacs open. So that way it doesn't take as much work to get more air in and diffuse that CO2 out and oxygen out, is what it does.
So basically a collapsed alveoli, you can't get any gas exchange.
Correct. Yes, like the early picture. This is the air sac here, and air's coming in, and this is your blood supply. If this is collapsed, the blood comes through there and says, all right, I got nowhere to drop off my CO2, and I got no O2 coming in, so I'm going to bypass you and move on. And it goes back to the heart without oxygen. Yes, sir. All right, so this is a 48-year-old female, and been smoking since 13, complaints of cough, heart rates. Respirations are tachypnic in the 30s, blood pressure's fine. She's sat at 88%. Don't know if that's normal or abnormal for her. She obviously has COPD because of that. She's anxious, using accessory muscles. She's tripoding. She's wheezing throughout. So again, this is a respiratory problem that we're probably going to think is going to be COPD versus asthma, right? They probably have underlying heart disease. They've been smoking that long as well. So COPD is a progressive disease where you get mucus production in these air sacs. So there, if you have mucus here, obviously you're not going to get good gas exchange. So they retain CO2. They also don't have a lot of O2 because it doesn't diffuse across all that snot, right? The other problem with COPD is you get bronchial constriction, right? So these things constrict, so you have less of an air sac inflated to get gas exchange. And the other problem with that is a lot of these folks get irritants from the tar, the chemicals that smoke goes in, and it damages some of these cells. So some of these cells get really thick and it makes it hard to diffuse gases. So they got a three-way problem having issues with that. So COPD is not a good thing to have. The way, other thing they get is sometimes because of the damage to the tissues themselves, you get blebs. So this is a lung. Lung should be nice and pretty and pink and smooth. This is a bleb. This is where the air sacs have been damaged from smoking and they kind of balloon out, and we use the phrase almost like a bike tire that's kind of weak, how it balloons out. I can show you these things in the lab when you come to Cadaver Lab in June. When we get that rescheduled. If you haven't been to one of our labs, you need to come do that. Really good learning stuff. And you also see this black tarry stuff that's damaged lungs from smoking. So big issues with that. People with COPD are known to have spontaneous pneumothoraxes. These will get really thin and then pop, and you get a small pneumothorax. So you got to be careful doing that, especially if you start to do BiPAP or CPAP on them. So the way we treat these guys is with beta agonists or anticholinergics. We want to bronchodilate them. Oh, that was quick. So beta agonists will be something like albuterol, which most folks carry. There's another drug out there called Xopenex. It works similar. It's basically just, it's like albuterol, has less side effects. It's more expensive. There's some data says it works better, but not 100% convinced. But albuterol, Xopenex, very reasonable to do. Most places talk about you give a neb treatment of 5 milligrams. You can repeat it 3 times, and after that, you want to do it every hour or so. There's really no good data on that. There's no way to determine how much of a neb treatment somebody inhales. So the way I manage this is I give them a neb treatment. If I finish the neb treatment and they're still working hard, wheezy, and look like dirt, they get another one. And when I finish that one, if they're still wheezy, working hard, and look like dirt, they get another one. The only risk is twofold. One, they may get tachycardic, and if they're old and have heart problems, that can be an issue. So if heart rates get above 140, 150, you got to back off that. The other problem is, what can albuterol be used for as far as another treatment besides COPD? Asthma. What else? Causes EKG changes, dialysis patients, hyperkalemia. So if you give somebody a boatload of albuterol, you're going to make the potassium level get low, and sometimes you can see dysrhythmias. So that's been documented in kids. You're not going to see a problem with 5 or 6 nebs. After that, you're probably going to see a problem, but most folks aren't going to be on scene with somebody to give them 6 nebs. Anticholinergics will be ipratropium bromide or Atrovent, pretty good drug. In the hospital, a lot of the docs say you give this twice a day. That's all you need. In reality, you could probably give them up to 15 milligrams or about 3 doses before you max out the receptors and you have no benefit. In the hospital, I usually give albuterol and Atrovent mixed. I give 3 back-to-back. If they get better, I smile. If they don't, I give more albuterol and I'll back off to anticholinergics for about an hour and then I'll restart it. So you can max out on Atrovent about 3 doses. After that, you probably need to wait another 30, 45 minutes or an hour before you give any more because you kind of maxed out the receptors there. But limited risk. Ipratropium bromide will not make you tachycardic. Okay, so if you got somebody who's already tachycardic and old, and you give a neb treatment, now the heart rate's 160, back off the albuterol and do just the ipratropium bromide.
Hey, Dr. Ferguson, we've got a question from online. I'm sorry.
Right. I'm excited.
It's a little late. It took me a minute to notice it, so I apologize to the person who asked the question. But the question reads, for patients not tolerating CPAP or BiPAP, is there an option to sedate enough to tolerate the treatment? And I think I know what they're talking about. I think we've all experienced the really anxious CHF patient who can't really have the mask on their face, just won't tolerate it at all. So what's your thoughts there?
So there's a role for sedation with CPAP or BiPAP. So if you look at our state protocols, it's contraindicated. In reality, in practice, it's probably better to sedate someone a little bit, give them an anti-anxiety medicine, and do BiPAP than to completely sedate them and intubate them, right? Risk to benefit. So there is a role for that. I've done that in the past. I'll take somebody that's a little anxious with it. I'll give them a low dose of benzo or something, and then try to BiPAP them and see if I can bridge them to breathe better. And then after they breathe better, the anxiety will wear off as well. I think it's a reasonable approach in the pre-hospital world if and only if you have an active medical director that you can talk to and get plans and be prepared to what happens if they quit breathing. How do I manage that? And you have something in writing in advance. I don't think you can, I doubt you're going to get a med control guy in Alabama to take an online call to sedate somebody to put them on CPAP or BiPAP. But I think if you plan in advance, then that's a good thing to do. That kind of answer the question, sort of? All right, good. If you understood it, anybody can understand it, so I'm good. All right, yeah. That was funny. So typical appearances. What? What'd you say? So, but in Alabama, we have bigger folks. So you have people who have COPD, asthma, who are also obese and have sleep apnea and retain CO2. So these guys are tough to manage. So if I was going to BiPAP or CPAP this guy and he was a little bit altered, sometimes I put a nasal trumpet in. That pisses them off enough that you can put the mask on. They breathe really good for a little while, blow off CO2. Now they're awake and alert, take the mask off, pull the trumpet out, and do fine. So, food for thought. Asthma is similar to COPD. You usually see it in younger folks. A lot of folks have seasonal asthma, exercise-induced asthma. People who have real underlying significant asthma are scary to manage. Questions to ask every asthmatic patient is, have you ever been admitted to the hospital for asthma before? If they say yes, that tells you they have really serious disease, high risk to be intubated or admitted, and a bad outcome. The next question, you ever been intubated before? Now, I used to make the mistake, you ever had a breathing tube before? You ever been on the ventilator? And everybody was saying yes. I'm like, what are you talking about? And everybody thinks that neb treatment is a ventilator. So I make it simple. You ever been into ICU and have a tube shoved down your mouth, okay? And if they say yes to that, they are high risk. These guys, even if they look fairly well initially, you treat them aggressively. If you've ever been intubated for asthma once, the risk of being intubated again is super high. The risk of dying is pretty bad. So severe asthma is a horrible disease. So very two pertinent questions you want to ask, okay? So we got a young person, history asthma, diaphoretic, tachycardic, blood pressure's fine, breathing pretty fast. Treatment management of this patient's sort of like COPD. So obviously I can get some O2. I'm gonna start doing inhaled beta agonists, albuterol, Xopenex, Atrovent. I'm gonna get them with those really quick and hard. I'm gonna do 3 or 4 back-to-back treatments. If the patient is an extremist, if they're diaphoretic, they're hypoxic, they're altered, they're kind of fighting me, Epi works great. That is a beta agonist. We used to give terbutaline for this a long time ago. Epi works great. It's a young person. I'm not going to cause them to have a heart attack from this. So 0.3 to 0.5 of Epi-IM is wonderful for this, folks, especially if they have multiple health problems. So young girl, really obese, anxious, diaphoretic, can't get IV access, won't sit still for the neb treatments. I'm going to pop her with Epi in one arm as I'm looking for an IV as I'm giving neb treatments. If she gets better in 3 or 4 minutes, I'm going to keep going for my IV and more treatment. If she doesn't get better, I'm going to hit her with Epi again in 3 minutes. Get bronchodilation. All right, maybe I can get her to calm down enough to get neb treatments. Then I'm going to get IV access. Once we get IV access, we give steroids in the hospital, not because they work fast, but because they do work, and it takes about 4 to 6 hours to kick in. So the sooner I get the steroid in, the better off they are in 6 hours. So this chick working hard, obese, she can get IM Epi. I'm doing neb treatments as I'm working on IV access. Once I get IV access, I'm going to give her a dose of a steroid, and then I'm going to give her a dose of mag sulfate. Mag sulfate is a great bronchial dilator, smooth muscle relaxer. She gets 2 grams. She gets that over about 10 or 15 minutes. Some places say you got to give it over 30 minutes or an hour. Magnesium can lower your blood pressure. It's usually at the 4 to 6 gram dose, the eclamptic doses. 2 grams of mag is not going to drop your blood pressure on somebody. We give mag also for torsades, and we give it IV push. So if I'm in the ER and I have the mag drawn up, I'm going to give it over a couple of minutes. Hospital personnel like to give it over at least 10 to 15. I think our protocol says 30 minutes. Is that what it is? 20 minutes. Yeah. But the point is, if they're in distress that I'm giving them epi for their asthma, they're getting mag pretty quick. So magnesium is a good drug to give. If you have concerns, I would call med control. Once you get the patient semi-stable, she's got a couple of doses of epi, she's got neb treatments, you know she's been intubated before, she looks like dirt. Hey doc, this is medic so-and-so. I got this obese chick who has asthma, who's diaphoretic, about to crash. I'm giving epi. I'm gonna give a bunch of mag. Any reasonable ER doc in the area should say, yes, give that mag, and then you just push that magnesium in.
So doc, we've got a couple of questions. So I asked one related to asthma first. Unfortunately, in the last couple of years, we've had a few fatal cases where young, otherwise healthy people had asthma. They had a severe asthma attack, went into cardiac arrest.
Yes.
It seems like they're always exercising or just finished exercising when that happens.
Okay.
And they tend to be very difficult to manage in cardiac arrest. Their
Yes.
chest feels hyperresonant.
Yes.
Any tricks or thoughts on management?
So what's going on? So they get bronchoconstriction. So they have, again, I'm not a great drawer. That's the heart, that's the lungs. All right. So with asthma, you get retained air in the lungs. So their lungs are hyperexpanded. They have extra air in there. And that air has CO2 and a little bit of oxygen. So the perfusion standpoint is this goes through, the body releases the CO2 because they're hypoxic, but can't pick up much oxygen because this air is not going in and out, right? So things that we do wrong in asthma is in cardiac arrest, we think, all right, we got to ventilate them 10, 12, 15 times a minute. In asthma, you probably want to slow your rate down. So you want to ventilate them maybe less, maybe 6 times a minute. And this sounds corny. You may want to put your hands on the chest and help them expel gas to get that CO2 out. So you can get more oxygenated air in and get better gas exchange. Other thing you want to do is they need epi. So if they're asthma patient who goes into respiratory arrest and goes into VFib, yes, you got to shock them. Yes, you think about antiarrhythmics, but epi is what you want to do because epi is going to do what to the lungs? Bronchodilate. So they need early epi. Okay, does that make sense?
Yeah, great advice. So the other question comes from text message is, what do you think about the old rotating tourniquets for acute CHF?
No, I think that's no. I think with the CPAP, BiPAP that we have, we're probably better off doing that because remember, it's not total body volume up, it's just volume in the wrong place. So that's not going to help get stuff out of the lungs. So we need to lower blood pressure pretty aggressively, okay, and increase cardiac output. So I think you're better off CPAP, BiPAP, intubating, dropping preload, considering dobutamine is reasonable as well to increase cardiac output. So I think that's probably a better way to go. Other drugs in the hospital, Heliox decreases airway resistance. It's helium with O2. The problem is we can only get about a 40% FiO2. So if the patient's really hypoxic, it doesn't help you. Propofol, we use that for sedation. That it has a little bit of bronchodilation. Inhaled anesthetics, anesthesia machine like from the OR, some of that stuff works pretty good. We used to use drugs like methylxanthines, aminophylline. Those drugs are kind of gone by the wayside. I probably used that aminophylline twice in the past 10 years. It has a low therapeutic index. So if you give too much, you kill somebody. If you don't give enough, it doesn't hurt them. If you give just enough, it may help them. So really not a great drug. The big drug that I use now for bad asthma is ketamine. So if I got a patient that's not responsive to IM epi, neb treatments, mag, and I'm going to intubate them, I'm going to use ketamine. I'm going to induce them with ketamine, and they're going to get ketamine about 1 mg per kilo every 5 or 6 minutes. That's a great bronchodilator, and it's going to allow you to ventilate, and they're going to be able to exhale with that, and hope that you can get them turned around until your steroids kick in. I will not do that in the pre-hospital world unless you're advanced practice, because that's a big dose of ketamine, and people can die from that too. So building blocks, I think we're running a long time. I'm not talking about a lot of that stuff. I do want to talk about any intervention you do with somebody. You got to think about 3 things once you intervene with somebody. Does it help them? Does it herp them? Herp them. That's a good word, herp. Shit. Do you help them? Do you hurt them? Beep. Sorry, that's where I got a delay. Please beep that out. Or is there no difference? All right. So if I got somebody and they're not breathing well, I lay them flat, I put an OPA in, and I start ventilating them. If the chest is rising and fall, if their color is getting better and their sats are getting better, I'm doing a good job. I keep doing what I'm doing. If I'm bagging the dude and now there's vomit in the mask, his chest isn't moving, his heart rate's going down, I'm going the wrong direction. I stop what I'm doing, I reassess. Maybe I reposition the airway, maybe I get a bigger OPA, maybe I just intubate them, okay? So anything you do, you got to determine, does it help them, does it hurt them, or do nothing for them? King Airways, I'm not a big fan. They're out there you can use. Remember, the way this works is the tube goes in the mouth hole. You inflate the balloon. This opening goes over the cords, and you ventilate that way. Remember, though, all the side effects of positive pressure ventilation, hypotension, damage to the lungs, you get with this, but you don't get all the benefits. The benefits being tube in the trachea, nothing in the belly. So no matter how good you place this, you're still going to get gastric distension and cause problems with the King. The other problem with the King is this big freaking balloon here may decrease blood return to the brain. We don't know yet. I'm not a big fan of it, but it's out there. The iGel, we're going to this a lot in the state, easy device. You basically lube it up with some KY jelly, or sometimes I just stick it in the patient's mouth to lubricate it, and you shove it in and it covers over the glottic opening, and it's another indirect method to ventilate these people. All right. Remember when you're using these that, well, we'll talk about that in a second, but that's the iGel. You can hook this up to waveform capnography. I do that sometimes and see if you're ventilating them pretty good. You get good ventilation with this because the chest is able to go up and down. I'm not convinced you get great oxygenation. So I'll see these put in where you use them to ventilate somebody. I get a CO2, 30, 40, 50, so I know I'm ventilating, but my sats are pretty crappy in the 60s or 70s. So I think these are great to ventilate, but for oxygenation, I'm not sure. I'm not convinced just using the bag, OPA, and having two people, one person hold the mask and somebody ventilate is not better. Big things about intubation. If you intubate someone, you got to confirm placement. The days of saying, I saw it go through the cords, the days of saying, had no belly sounds or saw mist, those days are gone, folks. You know, if you want to say you see it visualizing passing through the cords, great, but that doesn't impress me at all. If you got bilateral breath sounds, that's good, okay? If you got no abdominal sounds, that's good. If the chest is moving, that's good. If the patient gets better, that's great. But intubation in the field or the ER, you got to confirm it with waveform capnography. The state requires it, so that means every ambulance service has it, so use it. If you don't have it, use the kilometric, the easy cap. Then find this and do your waveform. You cannot defend an esophageal intubation anymore, guys. I will say that if you have not intubated the goose at one point in your career, you haven't done a lot of intubations. And that's okay. Everybody's done that. But you got to recognize it with that first or second breath. So if you hit the wrong hole, you got to recognize it. If you don't, somebody dies. People do not live with tubes in their belly, okay? They will live with no tube in the trachea or no tube in the belly sometimes. But if you tube the goose, they will die. So the way you confirm it is waveform capnography. So guy becomes altered on the scene. I go to intubate. I put my tube in. I'm going to ventilate afterwards. I hope to see mist. If I do, I still smile. I'm going to listen over the belly. I should have no belly sounds. I'm going to listen over the chest. Could have symmetric rise and fall of the chest. I'm all happy. I put waveform capnography on. If there's no waveform capnography, I'm in the wrong hole, right? So you got to use waveform capnography, people.
And I've got a couple of comments on the waveform capnography.
Sure.
One thing I still see people do consistently during cardiac arrest is stop chest compressions to listen for breath sounds after tube placement, after they've got a good waveform on the capnography.
Yeah, so I've done that in the past. I currently do not do that anymore. If I have somebody in cardiac arrest, I get them intubated, or if I don't, if I have waveform capnography, I'm in the right hole. So that is a good way. Don't stop CPR to do that. When you stop CPR for your next pulse check, then listen over the belly, listen over the breath sounds. Make sure you're not too deep. Make sure there's not a pneumothorax. Feel for sub-Q air, things like that. But waveform capnography will confirm your tube placement.
The other thing that's come to light since we've been tracking our cardiac arrest is occasionally you can get the tube in the belly and you'll get a really small diminishing waveform through just the first few ventilations if the patient's had a carbonated beverage or antacid. So it's important to look for that waveform and not pay attention to the end-tidal CO2 number.
Right, you gotta see the waveform. So some of the capnography machines out there give you an average capnography over a course of a minute or two. So you may have somebody that you think you have end-tidal CO2 return and it kind of diminishes down, or they go back into cardiac arrest. So you need to see that waveform is what you want to see. I agree. So pneumonia, just a quick touch base, no time for a short. Pneumonia is an infection of the lower airway. Pneumonia does a couple of things. One, the bacteria or virus jack up the lung cells, so the lungs can't produce surfactant, and it also causes mucus plugging, so like COPD, all right? And it also damages cells directly and makes them die. And then some bacteria and viruses call vasodilation. So the vessels that surround the air sac here dilate real big, so you get sluggish blood supply. So you get almost like a pulmonary edema in there because that plasma switches out. So pneumonia is pretty bad. Most people with pneumonia become hypoxic, but they can still ventilate. So the CO2 is fine, but they get hypoxic and they get better a little bit of O2. So pneumonia, we treat that with antibiotics, okay? That will help knock off the bacteria. If it's a viral infection, then we treat them supportively because antibiotics don't work for that. Just some x-rays, normal chest x-ray, x-ray with pneumonia, multifocal pneumonia, both lungs, very concerning. These folks can get septic very quickly, drop their blood pressure, become ill. This is normal x-ray. This is another multifocal pneumonia. In the right clinical setting, this could also be a pneumothorax. I mean, not pneumothorax, sorry, pulmonary edema. All right, so we got about 10 minutes. We'll talk a few minutes about COVID because I know that's a lot of people's mind, but I also know there's so much data going out on COVID that it's unreal.
Hey, Doc, I'm sorry to interrupt you. We did have one question from the internet.
Sure.
That I didn't get to. What are your thoughts on the use of racemic epinephrine for epi? Or what role does racemic epinephrine currently play?
So racemic epinephrine causes vasoconstriction. I use racemic epinephrine for stridor, so upper airway things, croup, epiglottitis, allergic reaction with angioedema. Some of the peds guys will use racemic epi for bronchiolitis because you get some of that swelling. And sort of like with that pneumonia, when I talked about you get vasodilatation of the air sacs, technically you could use racemic epi for that as well. That's probably more reserved for the ICU folks when normal measures don't work. So racemic epi, I would stick for croup, epiglottitis, stridor, or angioedema.
What did you say?
Yes, racemic, it constricts vessels. Yes, sir. It's epinephrine, so it constricts the vessels and it takes away airway edema. So if I had somebody who had angioedema, so again, I'm not an artist, that's their mouth hole, that's their tongue. Angioedema, swollen, big swollen tongue, I give racemic epi. It's gonna make the blood vessels in the tongue constrict. And so that no blood supply goes back to the tongue and the tongue will slowly get smaller. So that's the way racemic epi works. All right. So COVID stuff, let's talk one for the Birmingham region. Remember the state released last Friday, we're not quarantining crew members for exposure to COVID. So the first flow sheet that the state put out a few weeks ago is no longer valid. Obviously, still wear your PPE. You need a mask. They need a mask. If they don't have a mask on, the patient doesn't. You need a mask and goggles, at least a surgical mask. N95 is fine if you got it, but at least a surgical mask. But for an exposure, you're not being quarantined at home. What happens is you wear a regular surgical mask at work for the next 14 days. If you get a fever or symptoms, then you go home. You stay home until one of two things happen. You get 2 negative tests separated by 24 hours, which you're not gonna be able to get in this area right now because we only test people who are symptomatic. Or the better route to come back to work would be 3 days fever-free with no Tylenol, Motrin. And on day 7 of the illness, you're getting better. Then you can come back to work and you wear a mask for the remainder of those 7 days. So that's return to work stuff for the state of Alabama. Remember, if you're going to do anything that generates droplets or aerosols, you need to make sure you have on goggles, N95, recommend a face shield. Everybody's got gloves on, and you want some kind of garment protection, whether it be isolation gown or a raincoat or something that you can take off and get rid of after patient contact. And things that generate aerosols will be neb treatments. So we just talked about respiratory emergencies. If your patient is in distress, they're going to freaking die without neb treatments. We give them neb treatments, right? But you need appropriate PPE on. Get the right PPE on. Give the neb treatment in the patient's yard. Do it somewhere like that. Don't do it in the back of the box, okay? But if they need it, give it to them. If they don't need that treatment, don't give it to them at this point. I mean, you shouldn't do that anyway, right? So neb treatments, obviously anybody on CPAP or BiPAP, you need a full PPE, goggles, face mask, N95. Don't withhold BiPAP or CPAP from somebody that needs it. So we still have a large population of dialysis patients, people with bad heart disease that are going to get flash pulmonary edema, congestive heart failure, or volume overload. And those folks would die if we don't take care of them. So we still got to treat them, okay? But put on the appropriate PPE. If you're going to intubate somebody, you need to make sure you same thing, goggles, face shield, gloves, gown, everything. American Heart came out with some changes. We'll talk about this more next week as well. But basically for COVID-related issues, they want you to make sure that you're doing appropriate PPE for intubation and CPR. If you're doing CPR on somebody, American Heart says put a mask over the patient you're doing CPR on. Seems unrealistic, but what I would recommend is put something over their face so that you're not spewing stuff. I'm using a Chuck's pad or a sterile towel at work, something to keep them from spreading droplets. Now, be wise. On scene, you don't want to throw a raincoat over somebody's face while you're working the family's watching, okay? But be wise that you're not throwing droplets everywhere. The other thing American Heart is pushing really hard now is for intubation using a video scope. So if you work for an agency that has not bought a video laryngoscope, the time has now come to get those. American Heart is pushing that. Respiratory arrests need to be intubated early on because it's a respiratory problem, okay? The other thing is for securing an airway, preventing the spread of disease, you need an ET tube with a cuff up, all right? You also need a viral filter. Those are hard to find now for EMS. But I think when this starts to slow down, if your agency doesn't have those, it's time to start getting some viral filters that you can put on a BVM or an ET tube. But video scopes are going to keep your face away from the patient while you're intubating them and decrease the risk of you catching COVID, okay, in theory. All right. We talked about video scopes and Chucks. There are a lot of controversies out there with the COVID that's going on. There's a lot of data coming out. My advice to you guys is remember this is a developing story. Don't believe everything you see on Facebook or Instagram or even the news. We're not going to have a lot of real data for a year or so, okay? So we'll know what to do next time, all right? For now, use appropriate PPE, be smart. If there's someone that we can save and help, do that. If you got a 40-year-old that you arrive on scene that was jogging and now is in V-fib, don't be afraid to work that patient. Wear PPE, but we can make a difference in those kind of patients, right? If you have a patient that's known COVID and has a respiratory arrest, it's a little bit different. That patient, you got to have appropriate PPE. That person should be intubated with a video scope and not by DL, all right? So a lot of things going on now, and I know we're out of time. So if there are questions, put them on the chat box, shoot me an email, willfergusonmd@gmail.com. Remember, for your Con Ed certificate, Alabama EMS Challenge at Gmail is the way to go with that. Follow us on Facebook. We also have a web page. We're using the BRIMS website. All the EMS Challenge stuff is there, including our links. Next week, we'll talk about some STEMI cases. Again, we'll probably talk about some OB emergencies next week as well. I think that's going to be my agenda since we did airway stuff today. I will also update us some more on the ACLS guidelines. There were some guidelines that changed last week from American Heart. I know that there are two other organizations, NAEMSP, and I want to say American Academy of Emergency Medicine are kind of weighing in on those changes. And once I hear from them, we'll talk about what we should do in the area, if anything different. Questions, comments, statements within reason.
Yes, we got a question from online. It's COVID related. do we have numbers on positive outcomes of COVID confirmed cardiac arrest? Is it still worth the risk to the crew, or COVID arrest not recovering?
So some COVID arrests are recovering. There's not any good data, and there probably won't be any good data from that again for a year or so. I think you have to look at this from pretty high up. If you have an 80-year-old with comorbid health problems that is COVID that goes into respiratory arrest, then cardiac arrest, we still have a legal, moral, ethical obligation to workloads. But we all know that a person with advanced age and comorbid health problems that goes into respiratory arrest is probably not going to do well. Okay. Risk to benefit, I think that people that are COVID positive and have respiratory problems, that those folks you intubate with a video scope only. If not, you're going to use an alternative airway so that you're not doing a DL up in their face and you have appropriate PPE on. The current stuff that AHA put out last week is if you intubate somebody in cardiac arrest that is COVID positive and they're having a respiratory arrest that goes to cardiac arrest, that you stop CPR while you intubate them. And that is not everybody that we're doing, okay? Because remember, chest compressions are very important. So I'm kind of skirting the answer, I guess. The answer is, I think we still have an obligation to work these codes. Now, when you think about working codes in the field and transporting, it's different things. I don't think we transport anybody with CPR in progress because CPR in the back of a truck doesn't go well. If you have a Lucas, it's a little bit different. If you have a Lucas and they're persistent VTAC or VFib, that's reasonable to get them to the hospital for lytics like we talked about. Otherwise, I say we stay on scene, we work these people. If they meet criteria for death in the field or the total resuscitation, call med control. And there's nothing wrong with calling med control early if they meet those requirements already. But you got to have the PPE. That's the big thing. You got to have the PPE on.
So we got a different question here. Is early intubation with a filter better in a COVID arrest, yes, or BVM with a filter throughout the code?
I would say early intubation with a filter is better. So if you have a BVM and you have a filter and you got somebody that can hold that mask, that's reasonable to do that. But once you get them intubated, the cuff up and a filter on, you're not going to have any more respiratory secretions and droplets going at that point. Okay. I would still post-arrest put a towel or some kind of Chuck's pad around the patient's face so that nothing comes out of the mouth until everything's secure. Okay. But intubation is part of the way to go. But again, I think that intubation should be done by video scope so that you can stand back and not have your face in the patient's face. So
and that was a follow-up question or comment from the same person. Keeping in mind if there's no video laryngoscopy on hand.
Yeah, so no video scope. I can tell you what, one of the hospitals I'm working at now is that we're not intubating these folks without a video scope. We're going to use an iGel or some kind of supraglottic airway, place that with a filter, entitled CO2, and then we're going to cover the face while we're doing chest compressions so we don't spread droplets. If we get ROS, we're going to intubate. Now, if it's a purely respiratory arrest, I'm still going to use a video scope and intubate, inflate the cuff, and put a filter on there. So it's a tough call. You got to use common sense, though. I mean, you got to look at the patient. Not every cardiac arrest is the same. You got to figure out within reason what happened to them. Does that make sense? But again, guys, this is the time that you push whoever does your budget, time for a video scope. All right? The time has come.
Very good. I think that's all the questions we have right now. I do want to mention to everybody, there's been some problems with the form, and I'm gonna share the screen back here.
It worked just a minute ago.
Yeah, might finally work.
So if you get this message, this error message, actually it's not sharing for some reason.
You mean X out of this?
Let's see if they'll do it this time. Here we go. If you get this error message, one thing that you can do is you can try later, or you can copy and paste this URL at the bottom. And I have no idea why this works. Somebody texted me and told me this would work. So if you copy that and paste it into a new browser window, it actually takes you to the form. So if you could do that as a workaround, I would appreciate it. I have no idea why that error message is coming up today. It's never happened to us before. But that's it. So.
So guys, remember, if I said anything that sounded strange or inappropriate, reach out to us. If you have questions, reach out. If you have questions for your service, reach out to your offline medical director. They should be available to you. All right. And next week, we'll talk about probably GYN stuff, and then we'll talk about the AHA guidelines. Everybody can look at those yourself. And I'll get feedback from NAEMSP and AAEM, and we'll talk about those next week.
Very good. Hey, thanks for everybody for participating, and see y'all next time.